Welcome to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the new grad optometry world across Canada and the US. We are your hosts. I'm Dr. Amrit Bilkhu.
And I'm Dr. Deepan Kaur.
And we're finally back live on the podcast. I'm more excited than Deepan because I think she just woke up.
Early.
But we haven't been recording together in actually a while. Some of our episodes were pre-recorded. We had interviews from a while ago, and we're finally here in August when the episode will be released in August. And we actually haven't even caught up with each other in a long time. So we're excited to come back on. And we thought that today would be a great episode to share with new grads about how we've changed our refraction skills over time. Yeah, we're excited to share some tips on just changing your refraction so that not only will you build more trust with your patients and ensure they leave your office feeling appreciated and happy, but you're also preventing all those prescription rechecks. You're preventing some BV issues that you might trigger from overprescribing. So, yeah, let's get into it. But
Yes.
first, how have you been, Deep One?
I have been well. I have been surviving this heat wave. I feel like the entire world has been going through.
Yeah.
But things have been good. How about you?
I think I'm doing well. Like Northern Sight has picked up. And like I was
That's
telling
great.
you before, I'm getting a lot of BV assessments referred
Mhm.
to the office, which is awesome. So thank you for any doctor that has referred their patients to me. But speaking of the world just like getting hotter, okay, this is not related to the episode today, but have you also just noticed almost every single patient now complains of allergies and dry eyes?
Yes.
And
Yeah.
people are like, I've never had allergies before.
But
And now this year it's so severe.
we've been getting a lot of that wildfire smoke
Yeah.
from all the wildfires. So I try to remind people of that. I feel like wildfires are kind of everywhere,
Hmm.
including not only Canada, but also in the States. Every day I
Yeah.
hear a
Yeah.
different fire happening in like California
Yeah.
or Oregon or Washington. It's crazy. So I feel it's a lot worse this year. So I feel like a lot of more people are complaining of those kind of symptoms and they don't
Yeah.
understand
I
what's
think just
happening.
breathing in a lot more toxins too. I've been telling my
Yeah.
patients, I don't know exactly why your allergies have kicked up, but I'm honestly blaming climate change for a lot of these things. Just
Yeah,
generally,
me too.
like, that's
Just
like,
throw it at climate
just
change.
throw,
Why
I'm
am
like,
I not feeling well? Climate change,
climate
climate
change.
change, climate change.
Go call your politicians. Don't get the allergy drop. Call your
Yeah,
politicians.
I'm sure
You
family
guys.
doctors are using the same thing. Why is my blood pressure so high? And I'm still on medication. It's not changing.
Climate
Climate
change.
change. Look, climate change. Climate change. Next. I know, even then though, I'll still these dry eye patients especially, I'll still because if they've never had it before, I'll usually prescribe like a baseline treatment, like the typical drops, hot compress, or
Yeah,
wipes, and they still never do it. So what's the point?
it's true.
They're like, I did it for one day, I felt great, and I'm like, oh, but then they're like 2 weeks later, it came back. I'm like, well, that's because you have to continue the
Continue.
process.
Climate change
But
is not improving. So
yes. I've been saying this for years. In the next 50 years from now, the whole world's going to look
different.
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 But hopefully we'll
Yeah.
be retired by then and we'll see. Not to sound negative,
Sorry
but
to any students who are going to listen to this in 20 years.
yeah,
Sorry. It's going to be so different.
they're like, oh my God, they were right. But
Yeah.
it's okay. No, it's okay. With AI, you'll have a robot doing most of your refractions and stuff. Hopefully you're gonna be in a room just analyzing the data. Maybe.
No,
That's
but
what
we
I
don't,
think is gonna
deep
happen.
on, we don't want robots doing refraction, okay? Because our whole talk today is about how to not,
You
how
can
to automate
customize your
your,
robot and be like, this is what I want.
no, you cannot
Okay.
automate your refraction. And
Yeah,
that is the
that's true. I will say that.
yes.
Yes.
Oh my
So hopefully
goodness.
that
Like,
doesn't happen to us in the future.
yeah. And honestly, everyone listening here, refraction does seem like such a boring, mundane, like, easy part of optometry that probably most optometrists don't care about because they want to get to the ocular disease and all that other stuff. But
Yeah.
refraction applies to every single patient that you have of every single age, and everyone
Mhm.
is so different. So I still cannot understand how we're taught to automate our refraction coming out of school and making it like the same
Yeah.
procedure for every single person and relying on auto refractions. It's when we go into, our tips and maybe our experiences with patients, I hope everyone listening really appreciates how important refraction is. That should be, I mean, for me, that's like the number one most exciting thing now about an eye exam because it can really change people's mood, mental health, their posture, their breathing, their symptoms. Like it can change people. And
Yeah.
so that's why we're here today to kind of share our tips on how not to automate your refraction.
And I think what you said is true. Like for a few ODs, refraction can be considered, repetitive, boring. You're more excited to do the other parts of the exam. That's true. Yeah. Sometimes I fall in that category, but even though a patient's refraction might be simple, it might not be as simple as you think.
Yeah. So let's kind of go into it. We have some tips here and I'll kind of start with them and we can share like our experiences, but what I've learned and I think what Deep One has learned too in the past couple years is if they are not complaining of vision problems, do not change the RX. If they can drive still, like if they're entering like 2030 and they're happy and they said,
Yeah.
"Yep, just here for my routine checkup and 2030 is in your driving requirements." Don't change the RX for the patient.
Yeah. And I
Just
know this
don't.
is controversial a little bit, especially for us, because, again, how we survive in our clinics is glasses sale, right? So
Mhm.
totally understand that. But I mean, at this point, you don't want to change the RX just even by that quarter of a diopter just to, oh, there's a change there. You got to change your glasses
Yeah.
up. I know we don't talk about this a lot, but I know a lot of us do that, but that can be detrimental to the point where the patient will be like, um, I'm sensitive to this change. They're going to come back for like
Mhm.
an arc tech. And I know it's small, you don't think it's a big deal, but it can be affecting their binocular vision, to be really
Mhm.
honest. So I 100% believe in this. If they come in and they're like, nope, no issues with my near vision, with my distance vision, no headaches, no problems. I haven't been having any issues with my focusing system, nothing. I'm just here for just to make sure my health is okay and all that stuff.
Yeah.
And if they're, when you're refracting, they're like 2030, 2025, and
Yeah.
you can get them down to 2020 with a completely different refraction, I'm keeping that prescription
Yeah.
pretty much the same
Yeah.
because they're happy with it and they're not showing any symptoms of
Yeah.
anything else. I'm keeping it the same.
Yeah, and a lot
So,
of people, like, especially practice owners, yeah, I agree with Deep On. They might not agree because of making sales, but
mhm.
there are ways to do this and build trust with your patient so that they
Yes.
still make sales. Your wordplay is everything. So, I still will do a refraction on someone who's 2030 and find what is their refraction to get them to 2020. I'll let them know there's a very small change this year and I'll show them the new change because that's also one of our tips coming
Mhm.
up. But I will say things like, you know what? If you're happy with what you have right now, you can actually keep your glasses the way that they are. That's no problem. It's not going to harm your eyes. It's because people think that too. People panic and say, well, what if I wear my old glasses? Am I like,
Yes.
is that going to make my eyes go bad? I'll be like, no, you can totally
Mhm.
keep those lenses. If you want something sharper, here's the sharper option. I'll give you the prescription and it's always up to you if you want to change your lenses, but you're okay with what you have.
Yeah.
That just saying that builds trust with the patient so that
Yeah.
now you've shown them something a bit better. Now they can make the decision if they want to get it or not. And coatings on lenses really only last like a year before
Yeah.
those minor scratches come out. So why don't you use the same prescription and just get your lenses replaced?
Yeah.
And why don't you get a second pair? Keep your old pair for, going out and in the car. Why don't
Mhm.
you make a second pair for your vacations or for
Yeah.
when you're home or, whatever?
That's
You can
exactly what
still
I
make
say, yeah.
sales. Yeah.
Yeah, so I'll talk about something else, like their frame. I'm like, "Do you like the style
Mhm.
of your frame? Is there something particularly that's uncomfortable about your glasses or something like that?" And yes, the coatings, like I'll check for any scratches. Or if they have prescription sunglasses, I'll bring that
Mhm.
in. I'm like, there you can switch
Mhm.
back and forth. And yeah, I'll be like, you can get a second pair, switch with this old pair. It'll be fine for you. But yes, that is true. A lot of patients do get anxiety about, they'll always ask me, what are my numbers? What are my
Oh
numbers now? And I'm like,
god.
oh,
I
and they're
hate
like,
that
okay, is
question.
it worse? Is it worse? And we all know, yes, maybe it got a little bit worse, but it's not like, it's not going to destroy their whole entire health, right? But I think when you basically keep it the same and talk about all these other things,
Yeah.
it does help reduce the anxiety, but it also is kind of the really good advice for
Yeah.
patients, right? To keep them
Yeah.
and to build trust because they're probably expecting you to say, yeah, there's a change, go get a new pair. But if you kind of explain why you're saying what you're saying, yeah, I think that definitely builds more trust with
Yeah.
your patient and that
Okay, I'm gonna go
relationship.
off. I feel like we're gonna go off on a lot of tangents when we talk about these things now. The fact that you said when patients are nervous that their number got worse. Oh
Yeah.
my goodness. I
Yeah.
hate that so much. I tell every patient, and I get a little aggressive when I say this too,
Me
because I
too. I get triggered. I'm like,
Deepon
ah,
and I speak with passion. I have to look at them and say, there is not a single prescription out there that is bad if you
yeah.
have good vision wearing it, okay?
Yes.
So I'm like, "Yes, you went
That's
from a -2 to a -6, but you can drive now, okay? Like, you can drive
yeah.
now." I'm
I
like,
know
"So
that's
actually the
yeah.
-2 is terrible, and I'm
Yeah.
so happy that now you're a -6 and that you can see and that you can
Yeah.
thrive." And then
Yeah.
they look at me and they're like, "So is it a bigger number?" Like, "Don't
Yeah.
talk to me, get
No,
out
I
of
know.
my
And
room."
then I get
Yeah.
really triggered by that question because I'm like, even
Nothing
they'll
is
ask like,
bad.
what's the whole prescription? I'm like, I'm gonna print it out for you anyways. Like, why are
Yeah.
you asking me this? But anyways, it's just they just think the higher their prescription is, that's like I've had so many people ask me to, am I gonna go, especially myopes, am I
Mhm.
gonna go blind? And I'm like, and then I'll say that, like what you said,
Yeah.
like with correction, as long as you're able to get to this Snellen line, you
Yeah.
are
You're good.
fine. Like
Yeah.
just because your prescription might be getting worse, you're not gonna go blind. And
Yeah.
um
Yeah.
then they start to
It's
understand a little bit more. But yeah, there's a lot of anxiety about that, which
there's
I
a
was
lot of
kind of
mental
surprised
health
about.
there's a lot of
Yeah.
mental health, aspects of refraction on your patient,
Yes.
sorry, that we don't learn about in school, and I don't think we're paying attention to when refraction is so repetitive, automated,
Mhm.
and boring, right? You don't
And
understand
this
how
tells you
Mhm.
about their personality too, right? Like if they're
Yes.
getting nervous and they're like, "Oh, I don't know if it's one or two, like just I don't know." And then you're like, "Okay, well this person is quite
Yeah.
anxious." So it tells you a little bit more about their personality, how they're
Yeah.
probably using their eyes. So
Yeah.
there's a lot to a refraction as we're
Yeah.
going off on our
That was
tangent
tip number 1 that we started with.
for like 10 minutes.
I mean,
Tip number one.
tip number 2 is actually tip number 1, but when we say if they're not complaining, don't change the RX. If they also enter as 20/20 VAs, do not change the RX
Yeah.
unless they're complaining, because most of the time you end up giving them some like a quarter or 2 stronger, and then again, then the headaches show up because they were already comfortable, and now you've shoved them into a position where they're focusing a little bit harder than usual.
Keep it the same. But of course, if they come in and they're like, it's all blurry, it's all this, and you're like, okay, well, let me maybe give them that click. Maybe that
Yeah.
helps. But we'll get into this too. Like trial framing is
Yeah.
important too. So,
Yeah. I wrote this next one. Let's stop asking, is it better one or two? Obviously, I don't think the world is going to stop asking, but we're taught that in school, better one or two, which option, just noticeable difference. That causes so much anxiety for every patient. Every patient knows about the eye doctor just by the eye doctor asking them one or two. You're first of all, giving the patient the choice to create their prescription. You're letting the patient know you are in charge of how clear or how blurry you walk out of this room today.
Mhm.
Right? So the patient's already freaking out saying, "Okay, well I really don't want to mess this up because if I say something wrong, I'm going to get the
Mhm.
wrong prescription and then I'm not going to be able to see well." And in a BV perspective, when we already do refraction behind the phoropter, we're already triggering that proximal accommodative response. If you guys remember, right? Having an object very close to the eye triggers accommodation just from how close it is. So they're already over accommodating in the phoropter. And then when we ask them one or two, now we are making them panic. And so now their mental health accommodation triggers and now they can't focus behind the phoropter. They're fluctuating anyways. They're
Mm.
freaking out.
Oh, yeah.
So every
That stress
option is going to
response.
be,
Yeah.
yeah, it's a stress response. Every option is going to be semi blurry,
Yes.
right? Like even if it's a 5% blur, everything is going to be slightly blurry because they're already freaking out. So we can go into, tips that we've kind of developed over time. I know I don't ask better one or two at all anymore. And that's my refraction method. But Deepon, like how have
I
you like do you still do that or how
I
have you
will
changed?
only ask it maybe twice if I know there's a huge significant difference between both options.
Got
If
it.
I know there's going to be a small difference, it's when you start asking it more than 3 or 4 times, I feel
Yeah.
like the patient will be like, "Oh my god, these options look exactly the same. I don't
Yeah.
know." And then they're like,
Yeah.
"What do you want me to say?" Sometimes I try to remind the patient, like, it's okay if they look the same. Just
Yeah.
let me know.
Yeah.
But then they think in their head, like, no, like one has to be better than the other because they don't understand what we're doing. I didn't realize how many people get nervous about that
Yeah.
because they are nervous about how they're going to respond and what kind of prescription they're going to get.
Mhm.
And if we're going to make it worse by increasing their
Yeah.
numbers. So there's this whole thought process that goes into it because I remember when I used to go to the optometrist. I never thought about it. I just was like, yeah, that's clear, sounds good, whatever, moved on. But
Yeah.
there's a lot of anxious people out there
Yeah.
again that come into our rooms that have those kind of personalities and I have to reassure them. I'm like, "You know what? It's not your job to figure out the refraction. I'm going to do that. Just
Yeah.
relax. I'm going to take my time. You respond however you want and I'll figure it out." If I'm getting a difficult refraction, it's because of what Amrit said. There's some
Mhm.
sort of stress response happening. Everything's blurring, and we'll just have to take a break for a second and then
Mhm.
maybe go back to it. If I'm just trying to find the slightest difference where the patient's gonna be like, it looks the same, I try not to do one or two because I know it's just gonna, again, cause a stress response to them. So
I
that
like what
was,
you said about how you speak to the patient because that's a big one.
yeah.
You could still do a, better one or two method, but it's really just all about how you speak to the patient and
Mm-hmm.
how you inform them of how the procedure is going to go down. And
Yep.
that's the thing. I like the idea of refraction being something that the OD is in control of, not the
Mhm.
patient.
Yeah.
Like the patient's opinion should not matter in your refraction. It should matter in the trial frame.
Mm-hmm.
Like that's how I see
Yes.
it, right?
Yeah.
When someone's behind the phoropter, I am manipulating lenses until the patient gives me the response I want. And then when they give me that response, I move out of the phoropter, throw on the trial frame, and I'll say, "How do you like it?" Because if you
Yes.
don't like it, I can fine tune it for you. And so
Yes.
again, it's making the patient feel like I'm customizing an experience for them. And then
Yeah.
they're always happy with the trial frame because they didn't see any other option.
Yeah,
And
and
and then they're like, "Oh,
that's
it's
so
great."
true. I feel like honestly, I've said this so many time in our podcast, optometry is not it's all about, like, psychology of the
Yeah,
patient, right?
it
You're
is.
dealing with someone that's either, carefree, nervous, there's always these different personalities coming in, and you have to sort of match your personality to that.
Mhm.
I feel like we have to put on a lot of faces for different people, and I don't think we talk about this enough, but I remember again during my rotation, there was an optometrist that told me, whatever you do in the room, it's all like psychology based because you're dealing with
Yeah,
so many
it's
different
so
personalities.
true.
So, someone's off-putting personality might affect yours, but you kind of have to like figure it out, right?
Mhm.
This is the other thing I'll get to. A lot of patients be like, "Am I doing okay? Am I doing well?" And I'm like,
They ask for
"Don't worry." Yeah.
reassurance.
They
Yep.
exactly. They ask for reassurance because those kind of patients too, that they what's the word for it? They are people pleasers because they are
Mhm.
trying to be like, "Am I doing a good job? Like, am I helping you in any way?
Yeah.
Like, is this
And I'm
right?"
like, "You're
And
not
you're just
helping
like,
me if you're talking. Shut up."
yeah, yeah, exactly. And then okay, this is a people pleaser. They're
Yeah.
trying to please me. That where I'm trying to figure out the refraction. Or you have the anxious person that's like, I don't know one or two. Like they look the same. Like I don't understand. So there's like like it's probably the similar prescription, but there's just
Yeah.
different things going
Yeah.
on that you have to kind of control in the room.
Yeah.
So, yeah, it's, take your time with it, be nice, be calm,
Yeah.
joke around a little bit. I tried to bring humor in the
Yeah.
situation. It calms down everyone. But yeah, that's why I say if you're going to be an optometrist, you got to have a little bit of personality within yourself. I'm serious, dude. Like
It's true.
this is one thing I've learned. Like
Yeah.
a
I
lot
honestly,
of
that's not just for optometry. That is healthcare
yeah, like
professionals in general.
if you're in
You have
optometry
to
school
have
right now and you're like, I'm struggling with these courses, if you have a personality, if you can make a
you'll be
person laugh,
fine. You'll
you'll be
thrive.
fine. People
You'll
will come
thrive.
back to you. I'm telling you. Like,
Yeah.
it's okay if you don't know everything theoretically. You can always work on that, but not everyone is gonna have a great
Yeah.
personality. That might be a controversial comment as well, but I'm just
Maybe we'll
saying,
do a whole episode about personality
yeah. Again, it's all about the
types.
vibe. It's all
It's all
about
about
the
the vibe.
vibe. Just
Um,
saying. Anyways,
Adding to this, I have been kind of working, in the last few months, I've been making some BV, courses for primary care ODs because
which
again,
is
these are
great. Thank you for that.
yeah, like
Yeah.
these are topics that I don't think people think about or want to learn more about because yeah, like who's going to take a course on refraction? People are going to think, "Well, I already know refraction. Like that's
Yeah.
dumb. Why would I do it again?" But it's these little tips that I've, collected over the last 4 years of observing my patients, manipulating my words, my wordplay, how I'm speaking to the patient, where I finally found what works best for me. I have this very specific refraction method that I've kind of relied on. So I find that the entering VA is super important for me, right? Whether it's uncorrected or corrected. Let's do an example. Entering VAs are 2025 in both eyes. So first of all, I already know both eyes are quite symmetrical in their VAs.
Mm.
So that already tells me in my head, I'm not even going to focus on a monocular refraction because both eyes
Mm.
have symmetrical VAs. And I, of course, do all my BV testing before the refraction. So
Mm.
then I know, okay, if they're an esophoria, a large exo, they have an accommodative issue, then I'm tying together what's their lensometry, what's their VA, and what's their cover test or, accommodative issue. Because then I know, do I need to manipulate that prescription to make their BV functions better or their symptoms better? I don't follow the auto refraction. I take it as another data point. Because if
Yeah.
I know what their lensometry is, with what their SIL is, what the access is, and everything, and then I see their auto refraction, if their SIL and their access are kind of similar, I'm not
Yes.
even going to do a better one or two.
Yes.
I'm not changing that SIL. I'm not
Yes.
changing the freaking access,
Yes.
right?
I'm the
If
same exact way for that. Yes.
exactly. If I look at the auto refraction that's less minus than their RX, I already know they're over minus. I'm going to attempt to do a refraction with less minus and see how they respond.
Yes.
I have not asked them once, what is better, one or two, better or worse, same, what do you think? Like, I didn't ask them anything. I have taken control of the phoropter. I know exactly what I'm going to give them.
A lot of
Done.
people, when you say one or two as well, they don't understand that too. So I'll like I remember early on when I first graduated, I do one or two because I remember in school they were like, don't just say one or two all the time.
Go
Switch it
three
up
to
between one
four.
or two, three or four. So I'd be like one or two, they'd answer two. Three or four, they still be like
And where's
2.
2?
Yeah,
Where's
where's
2?
2?
Can I
I
see
like
2
2
again?
better. I like 2. I'm like,
Mhm.
"Oh, that's not an option. So is it 3 or 4?" And they'll be like, "No, no, no, 2 was better.
Can
Can
you
we
go
go
back
with
to 2?
5 actually?" And you're just you're it's just
Yeah,
confusing to a lot of people because I think they just have a lot of stuff going on in their head.
yeah,
But the other thing I wanted to mention too is I always start their refraction with the lensometry results, whatever they
yeah.
were in their glasses. I know a lot of optometrists will start with the auto refraction.
Please.
Yeah, because it just I don't think I have ever done that even when I started out. I think I maybe did it once or twice, but I learned very quickly I have to start from what they are always wearing. This is why to me in my clinic, lensometry has
Is
to be on
so
point
it
for
has
me.
to be
It
perfect.
has to
It
be
has to
perfect.
be
I am
perfect.
such a harper on lensometry. Like if I get a result and I'm like, this
This
is not
doesn't make
making sense
sense.
to me. I will go outside again and get my support staff or my team to be like, "Can you please read this again?"
Mhm.
I like lensometry is one of my important things that I need as a data point for my refraction. But yeah, I know there's a lot of docs that will get their techs to put in the autos for the
Oh
phoropter
god, don't
and start
ever,
from there.
ever do that.
I
No.
I just I can't. I feel like we're just doing a disservice to the patient because we're just not giving them the right prescription and we're confusing ourselves because it could be
Yeah.
totally over minus, undercorrected, not right. The
Well,
astigmatism
I mean,
axis can be somewhere
it's
else.
but
Like,
it's not a mystery. Every
yeah.
single OD has learned this in optometry school. Autorefractors over minus. No one out there should not know that at this point,
Yes.
unless you're like first year optometry. An
Yeah.
autorefractor is great because yes, it gives us an estimate or a guidance as to what their vision is really functioning at. But it gives us basically an accommodative response to their refraction.
Mhm.
Every single person is looking through a tunnel, staring at this 2 millimeter hot air balloon. You are
Mhm.
hyper fixating on that hot air balloon.
And everyone is trying to
Everyone is
clear
over
that
minused.
image. Yeah, they're
Everyone
trying
is
to clear
over
that
minused.
image. Yeah.
So, Dr. Donati, who I work with, Virginia Donati, she has a lecture on her methods of prescribing as well and how to do refraction, from her experience. She actually graphed a lot of her patients from the book. No, she is
Mm.
a master at like getting data points from her
Oh, I'm
patients
sure.
over
Yeah.
time.
Yeah.
Yeah, she's very into that. And she made a graph that showed tons of patients that she's had, what their dry refraction was, what their auto refraction was just by saying, look at the hot air balloon,
Mhm.
and what their auto refraction was by saying, okay, try to focus really hard on that hot air balloon. She is so freaking cool because she literally graphed this, and you will see, first of all, everyone's dry refraction is less than
Yes.
their regular auto when you just say, look at the hot air balloon. Almost everyone's response was significantly more myopic when you say, focus on that hot air balloon and try to make it clear. Some
Mhm.
people's myopia shifted almost like 2 to 3 diopters
Yeah.
in the auto refraction. Again, just by wordplay and the fact that it was an autorefractor, not dry retinoscopy or dry refraction in like a phoropter. So, okay, another tangent that was,
Yeah.
stop
And that,
starting with autorefraction.
that could be important for training our team, right? Like
Yeah,
don't say focus on that image.
yeah.
Just say
Mhm.
look at it or try your best, right? I don't think we
Yeah.
do that at our clinic.
Wow, moving on. We got like 2 other points, but I think hopefully a lot of these points are resonating with people listening. This is a huge one for Deepon and I, and we've mentioned it before in one of our podcast episodes. I can't remember which one, but again, time and time again, trial frame every single RX in office, in your chair, in the room before prescribing. And I call it try before you buy. And
Mhm.
patients love it because, again, it builds trust. I find the patients are thinking that I'm not trying to sell them something. And I say, try this out. This is what we figured out. And tell me if you like it. And if not, we can fix it up and fine tune it. And I know
Mhm.
Deep One's the same. Like trial frame is just so helpful after your
Yes.
refraction.
I like to trial frame, yes, because it builds that trust between you and the patient, and it gives them assurance again that, "Oh, okay, like, look at this prescription. Yeah, this is working for me. Okay, yeah, this is what I'm gonna buy," or if it's like, "Yeah, it looks the same, maybe I'm not gonna purchase this year," whatever. But it gives that patient that assurance that you are not just trying to sell them something,
Mhm.
and, you're trying to show them how their actual glasses will look in the real world when they're trying to walk
Yeah,
around, look at a computer.
yeah,
Um I have found trial framing has really helped, like, at the beginning of my career, bring down my RX checks because
yeah.
it not only, again, the psychology of the patient, they know that you made them these pair of glasses that
That
they
they
can't
got to
see.
decide on with you, right? Like,
Yes,
this
and
is
then
where the patient gets to make a choice. Whereas,
yes,
like I was saying, in refraction, my patients don't get a say. I don't even give them
exactly.
time. But
Yes.
for trial frame, it's like, what do you
What
like? What do you hate about this? You tell me
Exactly.
now.
Yeah, and it gives them that, reassurance again that, "Okay, I've tried these glasses now, I liked them. Okay, I'm gonna go buy." And
Yeah.
then when they actually get their glasses, they're like, "Yeah, this is exactly what I tried in the room with
Yeah.
the optometrist." So, I feel like sometimes when you don't trial frame, but because you think like, "Oh, there was a slight difference, wasn't a big deal," and you still get that RX check back, I feel like if you did trial frame in that
Yeah.
time, you wouldn't get that RX check,
Yeah.
and I feel like it's
Yeah.
just
It's
the
that
psychology of the patient
psychology.
sometimes. So that's what I've learned with that. But yeah, I try to trial frame as much as I can. I know there's certain times where you're running behind whatever it is, or you've known this patient for a long time. You're like, okay, I know this is going to work for them, but try to trial frame as much as you can. I would make it a habit into your refraction because it
Or
does save time or help in the long run, really
to
in the
be
long run.
also ask your employer and ask your staff and your opticians, is someone else comfortable maybe doing a trial frame in the
Mhm.
optical or something, after you've finished up with the patient?
That's a good idea. Yeah.
That, in a busy practice, that's what every
Yes.
OD is going to say. I don't have time to trial frame, especially in corporate settings. You got
Mhm.
those like 10-minute eye exams booked for the whole day,
Mhm.
back to back. Why don't you designate someone to trial frame? They're literally reading the RX you've given. If they know how to put the lenses in that trial frame and have it on the patient, again, it's still a personal customer experience. That staff member can say, "Okay, this is what the doctor gave you. Let's have you try it on. Let's make sure it feels comfortable. Walk around the room, 5 minutes, 10 minutes, go on your phone, go look around.
Mhm.
Tell us if it's okay, or we'll bring the doctor back in to, fix it for
And
you."
I think there's some practices that probably do
They
that.
maybe do that,
I
yeah,
think,
I
yeah, that's
just
a
don't
smart way
know,
to
but
go about it. Yeah, I feel like a lot of clinics and optometrists kind of forgo the trial frame part. But
yeah.
I don't know. I think it is really important.
And I guess one more point on that, it's not just have them sit in the exam chair and trial frame it for them to look at the VA chart again. That like, I
Yeah,
find that
no.
that's what a lot of ODs do, right? Like,
Yeah.
a lot of ODs trial frame, but they'll trial frame with the patient looking at the 2020 chart again. And it's
Mhm.
like, no, have them, that's still a 8-foot room, 10-foot room.
Mhm.
Like, you're giving them a driving RX, a golfing RX, a sports RX. Have them stand in your optical, have them stand outside, take a look down the parking lot, look out the window. How does everything feel? If you're
Mhm.
giving them a computer RX and you've said, and they, the patient will sometimes put their arm out and say, "Yeah, I think my computer is this far." Well, you have a computer right there. I
Yeah.
have so many of my patients sit in my doctor stool
Yeah.
at my desk, and I'll put the trial frame on and I'll say, "Okay, pretend like this is your computer, sit far away, however far in your office. Now how does it feel?" And sometimes
Mhm.
I'm a quarter off, right? Like, because then they've
Yep.
actually sat where they are, and I'll give them an extra plus or minus a quarter. And then they're like, "Yeah, this is much better." And then I'm
Yes.
like, "Okay, there we go." I would have screwed it up. But
Yes.
yeah, have them
Yeah.
manipulate their environment as much as you can.
I think this was one of our next tips we were going to talk about, like certain lenses. Yes, an office lens versus a single vision computer lens.
Oh,
Lordy, let me tell you. Okay, I like an office lens for certain people, but the trial frame for a single vision computer lens versus an office lens,
it's
sometimes
different.
a single vision computer lens is enough,
They'll still be able
okay?
to read. They'll still
Yes,
be able to
especially
read.
for our early 40-year-olds, even
Yes.
45, even late 40s. They can still accommodate when they need to read
Yeah.
something up close. So, yeah, that is one of the biggest things for those kind of things, if especially with their near vision, trial frame because and yes, you everybody has a computer. And you have to ask people, especially with because everybody's on a computer nowadays, how many monitors are they looking at? Is it side to side or up
Or
and
up and
down?
down.
How are they moving their head? Because in an
Yeah.
office lens, depending on the design, they're gonna get major distortion if they're
Mhm.
moving their head around. So maybe a single vision computer lens is the best option, but
Yeah.
trial framing that is so important. And yes, this whole thing of like, oh, I sit this far, I don't know, like 40 inches away from my
Mhm.
whatever computer or
Yeah,
from
it's
sitting
not
from
the
the computer.
same.
It's not the same. And you measuring that with whatever math that is, it's
Yeah.
not the same. So what I do, yeah, I'll put on I'll go to the website People Magazine
Oh, you go
and
to
put
People?
that
I
up.
go to CP24
Oh, I put People because
because it's so small and,
they
like,
have
lots of
small
stuff.
lettering, they have bigger lettering,
Yeah.
and I have two monitors in my room, so I'll like switch it back and forth and then they will sit in my chair and I'm like, "Okay, just pretend this is your office and I just want you
Yeah.
to look at the keyboard, look at the computer, look on the other side. How are you feeling?"
Mhm.
And then they will let me know, like you said, oh, no, this is a little blurry here, or
Mhm.
oh, this is great. Oh my God, that has saved me so
So
many
much.
RX checks.
Yeah.
Like
Yeah.
I can't even. Oh,
Yeah.
biggest
So,
tip.
transitioning, I guess our last point that we wanted to kind of go through together were our lens recommendations, right? So Deepon kind of mentioned already, great point about single vision versus computer progressives. So I usually either will recommend a single vision computer lens, or honestly, I have found I've had more prescription rechecks with computer occupational lenses or computer progressive designs.
Yes.
I don't like how lens companies do this. It's stupid. They want the distance and the reading RX
Hmm.
for the occupational lens. And then
Hmm.
I asked them, well, how do you figure out the
I
RX
know.
for their computer distance? Oh, we cut it in half. We cut the reading in half, and that's what we blend in the middle. But it's not half for all
Yeah.
my like it's not half. It has to be customized. I will have patients with a +2 ad to read
Hmm.
up close, but their computer is the +150 ad.
Hmm.
It's not a
Hmm.
+1.
Hmm.
And they don't need that tiny little distance window to do what? To find the bathroom, like, in their office when they walk? They're not driving with these glasses, and they're not, and I tell my patients, the prescription I'm gonna give you, if you are someone who sits at a desk, 8 hours a day, I understand you're gonna get up and you're gonna walk to, go to the bathroom or go to another person's desk to go talk to them. I understand you're gonna get up. I'm not gonna give you vision to see clearly walking around your office. I'm gonna
Hmm.
whatever I'm putting in your lenses, these are gonna be to make sure that for the majority of your 8 hours, you are getting the optimal computer and paper prescription
Yeah.
for seeing clearly. And so I actually have stopped completely prescribing occupational lenses, or like the whatever where they add
Like you mean the
distance
like
and
an office lens
an
or
office
office
lens.
lens.
I
Okay.
don't do it at all. I found for me the most successful thing has been anti-fatigue lenses. And
Oh. Oh, so
and
you change it to their computer
yes.
RX and the
Yes, I
bottom
do
part
not
is
put the distance.
oh,
I
okay,
don't
okay,
put the
okay.
distance and let the optical figure it out. Again, I am in charge of my
Yes.
patient's RX, not the optical, not the lab, not my patient, right?
I
So
see. Okay.
I
Mhm.
always prescribe them 2 pairs of glasses. Their everyday glasses are progressives, right? Because
Mhm.
that's what they care about. Driving, walking around, so their distance RX is in there, and then pretty much spot reading.
Mhm.
because their everyday glasses are after work when they're out and about. They're
Yeah.
not, at home. Anyone in their 50s and 60s, they already have their readers at home.
Mhm.
They have something, right? But when they're out and about, you're spot reading, you're reading, you're checking the map on the phone, you're looking at the grocery list. You're not holding something 30, 40 centimeters from your face for more than 5 minutes or 10.
Yes.
Then for your computer, like when you're at the office, I am giving you an anti-fatigue lens that has the computer RX at the top and a little baby reading boost at the bottom. And
Yeah.
that is what I say because it's usually only a point 0.5 or a 0.75 boost
Yeah.
to read the paper. And they freaking love it. They're obsessed. They're always like, because again, I don't want all this blurriness. Nope. It's going to be a soft blend. It's going to be a little boost. Yeah, you're not going to be able to get up and, drive out for lunch with those glasses on, but those glasses should stay at your desk.
Yeah.
They are, and that's how I, advertise it as like
Yeah.
these are meant
I
for,
like that. I like the
yeah,
anti-fatigue for people who are sitting at the computer 8
I love
hours a
them.
day.
I love them. I've never
But I
had a
think
person
it's
complain.
yeah, I think it's also important to be clear about what you're doing.
Mhm.
Remember, you're giving a lot of information to patients all at once in the exam room, so try to be very clear about what you're doing
What the
and
lenses are
explain.
for, the purpose of the
Yes.
lenses.
Yes, and try
If
to, and
you
especially if they're going to be purchasing, glasses from your clinic, make sure you and your optician are on the same page
Mhm.
too, because they're gonna ask when you're with your next patient, they're gonna be
Yeah.
asking the optician, "What did Doctor Bilkhu just say to me? Can you just re-explain that?" And your optician
Yeah.
has to be able to
Yeah.
explain it, the way that you did. So,
Yeah.
yeah, I'm gonna probably try that anti-fatigue lens.
Because
I told you I don't like an
honestly,
anti-fatigue lens for students
or love
because,
it for kids. I throw it at all of them.
I don't like it for
But yeah,
university students or whatever because I feel like it doesn't, because when they're looking at their computer, they're
they're
not
looking
really
straight.
looking through
Yeah.
the part that's
Yeah, they're
supposed
not
to
looking.
help them.
Well, so what I've learned from that, and so yeah, I figured that out too. A lot of my younger people were not getting the boost from there.
Yeah.
So I told the opticians, I said, just I know that when you order an anti-fatigue, there's no seg height or anything, right? Because it's like a single vision lens.
Yeah.
But in the edger, I tell them in the notes of the RX, so I'll just let them know when you're marking that lens, put that lens a little bit higher up so that they get the boost. They get the
A little
blend
bit more.
almost in their central vision.
Mm.
Yeah. And yeah, play around. Like I was so confused in the beginning about computer occupational lenses because I was like, this is what the companies are saying is great for my patient, and then they're
Yeah.
coming in for prescription redos. I don't know what the hell's going on. And so
Yeah.
I had to, kind of figure out how to manipulate my prescriptions to
Mhm.
fit, the definitions of the lab's lens design. And do
Mhm.
that. Play around with it.
Yeah.
Play
I
around with
know,
them.
yeah, and that's true. Lens companies and stuff, they'll be like, "Oh, this is the perfect driving lens. This is the perfect computer lens," or
Mm, eh.
you gotta read
Sometimes single
into.
vision is
Yeah.
perfect.
Yeah.
Yeah.
Again, these are tips to help slow down those RX checks or decrease them, and hopefully some of them work for you guys. I mean, this is what me and Amrit have learned out of our 5 years of
Oh
practice.
my God.
So,
Oh,
I
5.
feel
Can we even do this podcast anymore? Are we relevant to new grads?
I think someone called me a new grad recently. They're like, "Oh, you're still a new
Okay.
grad." I'm like, "All right, we're still there." I mean,
Yeah.
yeah, hopefully these tips have helped. If you guys have any tips that you guys recommend, give it to us. Let us know. Or if you
Yeah,
feel
please
like
reach out to us anytime.
yeah, because I feel like everyone has a different refraction method. Refraction is an art. It really a little
Yeah.
bit of a science there, but it's mostly an art. And I
Yeah.
feel like every single person does it differently, but it's not like no one's doing it wrong.
Mhm.
But there's ways that we can definitely improve it. I feel like
Yeah,
even in 5 years
100%.
from now, Amber and I will have
Something
probably
different, probably.
different changes to our refraction method, but we're just learning as we go. And yeah. Thanks for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. We will see you guys next time.
Bye.
Bye.